The next of the major diagnostic features is the characteristic charge ears. And again, this is actually a set of features because it can be the outer ear, the middle ear, or the inner ear. And if we look at all of those, about 95%, the vast majority of people with charge have some issue somewhere in their ears. The outer ears of charge may be completely normal, or they may be very close to normal where only a medical geneticist would notice any different, or they could be so distinctive as to say, I've seen a couple kids where I've seen their ear and said, that child has charge until proven otherwise, because nothing else gives you that ear. So what characteristics do we see in these ears? One of the things that I really notice is asymmetry between the two ears. Sometimes one ear looks very typical, the other ear looks very unusual, or sometimes they both look unusual, but they don't usually look like each other. So asymmetry between the ears. They're often very floppy because of deficient cartilage. One mom described her child's ears as kind of blowing in the wind. As far as their shape, they're often short and wide, and there can be a clipped off helix. The helix is the outer fold of the ear, and the yellow arrow here is pointing to an ear that is missing that outer fold of the helix. One of the most common things we see and easiest to evaluate is a smaller absent earlobe, as you see with the green arrow. And another thing we describe is a triangular concha. The concha is like conch shell. It's the shell in part of the ear. And because the antihelix, the inner fold of the ear, can be very, very prominent, you can end up with a very significant triangular shape to the inside of the ear, as you see on the ear that's showing the blue triangle there. Sometimes all the folds of the ears are kind of missing, and you end up what can be described as a cup ear. So we see all sorts of different things with the outer ear. Seeing the outer ear does not predict what's going on in the middle or the inner ear. You can have a normal outer ear and be completely deaf, or you can have an abnormal outer ear and have much less hearing loss. There's really no correlation between the outer and the middle and the inner ears. This is a diagram of the inside of the ear, of the middle and inner ears. And the middle ear is the part that is right behind the eardrum. So there's the eardrum, and right behind it are three little tiny bones, and the eardrum moves and that vibrates the bones, and those bones then send the message to the hair cells in the cochlea for hearing. Those little bones may be missing, they may be malformed, there may be a lot of fluid in there gunking them up so that they can't move. Any of those situations will cause what is called a conductive hearing loss. When we move to the middle ear, or to the inner ear, excuse me, in the inner ear, one of the most significant things are the semicircular canals. And those are three fluid-filled loops that constitute the vestibular system, or the balance part of the inner ear. And probably the most common feature of charge syndrome is small, malformed, or absent semicircular canals. You can see this best by MRI, can also be seen by CT scan, but many children don't get imaging of the middle ears, the inner ear. They get imaging of their brain maybe, but not all the way down to their ears. So we often simply don't have that information. If there's a question of charge in someone, that's something I always recommend. Knowing about the semicircular canals is helpful in that it can help confirm the diagnosis. It's also helpful to know that if the vestibular system is not there, because that will help you know that there's going to be a lot of delay in motor development, because you'll hear a lot more about this later on, but balance uses the vestibular system, your vision, your proprioception, information from your muscles and joints, and your brain all put together help you balance. If you're missing that major component of the vestibular system, you have to figure out ways to use all the other information to be able to balance, and that's going to take longer. The next part of the inner ear is the cochlea, and that is the snail-shaped organ in the inner ear that contains the hair cells. That's the information that gives you the sensory neural hearing. In typical people, that cochlea will have 2.5 turns to it. In individuals with charge, the cochlea often has only 1.5 turns, resulting in a sensory neural hearing loss. Information goes from the cochlea to the brain via the cochlear nerve, also called the auditory nerve. And in people with charge, that nerve may be hypoplastic, which means underdeveloped, or aplastic, which means it's not there, it's absent. And if you look at in that red circle, there's the cochlear nerve, and sitting right on top of it is that facial nerve that I talked about earlier. That facial nerve goes through the inner ear. If someone's being evaluated for a cochlear implant, it's really important to know where the facial nerve is. It sometimes goes in an odd place in kids with charge. So you don't want to damage that in the process of putting in a cochlear implant. A little bit more about the inner ear balance problems. If you have small or absent semicircular canals, you are missing a major portion of the vestibular system that gives you your balance and your information about where you are in space. And that results in some fairly characteristic gross motor development early on. So when kids are crawling, they're going to want to stay close to the ground. They may do a combat crawl, sort of going along on their tummies, or a lot of them crawl on their backs and push with their legs. Sometimes if they are up there on their hands and knees, they put their head down for another balance point. We call that a 5-point crawl. They may do bottom shuffling. And we've always known that the age of independent walking in charge is very delayed, but the balance really explains a lot of that. If you look at typical children, when they pull to stand and they're cruising, walking along, holding on to furniture, it's about 2 months before they let go and are able to walk independently. If you look at children with charge, and when they pull to stand and they're walking, cruising, walking along, holding on to furniture, cruising, holding on to hands, that kind of thing, it's more than a year before they're able to let go and walk independently. And that's because of that balance information. They're not getting all the information. They're having to learn to use other information from their bodies to figure out where they are. And so that's going to really delay their walking. It has nothing to do with their intelligence. It has to do with their physical system and the balance issues. Beyond that, the vestibular system is also important for processing visual information and auditory information. If you think about when you turn your head, the image doesn't jerk along, it goes smoothly, and you can do that. That's because your vestibular information is telling you where your head is in space. So when you don't have a vestibular system, it's going to change your visual information and your auditory information, even beyond where your visual field defects are or what your hearing loss is. So that vestibular system is really important, and you will hear more about that later on in this lecture series. The last of the major diagnostic features is the genetics, CHD7 pathogenic variants or mutations. And about 80 to 90% of people with charge have pathogenic variants in CHD7 that we're able to identify with current technology. That's changed as the technology has gotten better, but it's probably never going to be 100%. Typically, these are what are called unique missense variants. Okay, what does that mean? Unique means it's the only one. It's a very large gene. You can have changes anywhere in it. There are no hotspots. For some genetic conditions, you can say, if we look at this part of the gene, we'll find half of all the changes that exist. That's not so with charge. They can be anywhere, and finding a change that's never been reported before is actually very common. Missense means that it's a change in the DNA that makes a protein that isn't going to be functional, as opposed to that you can have missense and nonsense and all different kinds of variants. And these are basically typos in the DNA. I'll say a little bit more about that in a minute. But I also want to say that there really isn't any correlation between the variant, the mutation that you find, and the features that you find. So you can't say, oh, if you have a change right here, you're going to have this kind of heart defect. Charge doesn't work that way. You can't predict it that way. And that kind of goes along with it not running true in families. If two people in the family, they have exactly the same change in the CHD7 gene, it's showing up differently. So you really can't say what's going to happen based on what kind of change that you find. A little bit more about the gene. It's a very large gene. CHD7 has nearly 200,000 base pairs. The base pairs are the A, T, G, C that make up DNA, sort of the spelling of the DNA. And what you're looking for is a single typo in that string of 200,000 base pairs. And the only way to find that is by specifically sequencing, reading every single base pair. So there are a lot of different kinds of genetic tests. Chromosome tests, microarray, many of those tests are not going to tell you about CHD7. So if someone they have genetic testing and it was normal, I always have to ask them, which type of genetic testing did you have? Because there's no one test that will give you all the information about all the different genetic conditions. So that concludes the major diagnostic features. Now I'm going to move on to the supporting or minor diagnostic features. These are a number of different things. Some are very specific to charge, but difficult to evaluate consistently. Some may be very common in charge, may be very important medically, but they're also very common in other syndromes. So they don't help distinguish between charge and the overlapping syndromes. And some are less common in charge, so they're helpful when they're there, but they're less likely to be there. Or they may not be present in the newborn period, so they don't help make a diagnosis early on. But these supporting and other features might be incredibly important for medical management, and some of the things you're going to hear about later in this course are these other features that are very important for the children that have them. They're just not particularly helpful in telling us, is it charge or something else? So what are these supporting features? Congenital heart defect is a big one. 70 to 80% of children with charge have congenital heart defects. Many of these are very complex, often life-threatening heart defects. And the heart defects really overlap a lot with the syndromes that are similar to charge. So extremely important medically, not incredibly helpful distinguishing is it charge or some other syndrome. Tracheal or esophageal anomalies happen in 20 to 30% of kids with charge. About 20% have cleft lip. 30 to 40% have some kind of a kidney problem. And that can be anything from extra fluid in the kidneys that doesn't drain out properly, to cystic kidneys, to a missing kidney. So any kind of kidney problem can show up. Hypogonadism or genital anomalies is a big thing in charge. You're going to hear a lot more about that later on. Brain changes, brain differences that you can see on MRI. There are actually some very specific differences in imaging of brain of children with charge, some of which may actually be unique to charge, but not enough kids are always getting that imaging that's moved up to the major feature. But if you go back to the December 2017 edition of the American Journal of Medical Genetics, there is one article very specifically on cranial imaging in charge, and they talk about what things are very specific to charge that you could look for. Growth retardation, including growth hormone deficiency, is not going to show up in the newborn period, but is perhaps a significant feature. Behavioral characteristics, particularly obsessive compulsive disorder and autistic-like behaviors. You're going to hear a lot more about those later as well. There are also typical physical features that if you're a medical geneticist who looks at how things are structured, it may be very obvious to you, but other physicians are less familiar with those things and may not be able to evaluate those as specifically. And these can include typical face, hand, neck, shoulders, and even toes. And I will show you the face. The typical charge face is a very square face with a broad forehead, large round eyes. The nose can have a very prominent bridge, a square nasal root, and a prominent columella. The columella is the tissue that's right between your nostrils, and that can sort of be very prominent, kind of sticking out a bit. a small chin that gets larger with age. And here you see pictures of a number of infants and young children with charge. And I think you can begin to appreciate that they look similar to each other. You can also see the typical charge ears and facial palsy on some of them. And here are some faces of older children and teens. Again, you can probably appreciate the ears and the relatively square face and the sort of kind of blocky nose and that sort of thing. And if we move to teens and adults, you can see these people obviously look like they're other family members, but I think on these pictures you can especially appreciate the very short, slightly webbed neck and very sloping shoulders on some of the people. There actually are changes of the musculature and sometimes the bones that give you the sloping shoulders, but that hasn't been really well defined yet. So when you're looking at these major and supporting features, how do you make a diagnosis of charge? The consensus generally is if you have 3 of the major features and at least 1 supporting feature, that's enough to get you a definite diagnosis. Or if you have 2 major features and 2 or more supporting features. So that's, and every clinician is going to come at this a little bit differently and put a little bit different number of different things in the supporting features and that kind of thing, but that's basically how we do that. Now, beyond these diagnostic features, there are lots of other things that we see in people with charge. So there are many, many, many other features that have been reported that are consistent with charge. So I'm getting at a couple of things. One is pretty much every organ system can be affected. Another is there's not much of anything you can say, oh, well, if a child has this feature, then it can't be charge. I'd be hard pressed to come up with any of those. But what are some of these other features? Some of it is the dysmorphology. I mentioned the web neck and the sloping shoulders. There's also the hockey stick palmar crease. Well, what's that? The hockey stick palmar crease is just, it's the upper crease of the palm that goes across, and then it kind of takes a sharp turn and gets very deep when it goes between the index and middle fingers. And you can see it best when you're bending your hand a little bit. My crease goes up there, but it kind of tails off instead of getting deeper as it goes up there. The hockey stick palmar crease is not unique to charge, but we do see it in a lot of kids with it. Palmar creases are simply fold lines, and so that tells you something about the shape and size of the bones of the hand and how the hand is folding. We also see lots of teeth abnormalities. Limb and skeletal abnormalities are actually very common, but there's no consistent pattern to it. We see extra fingers, missing fingers, even to the extent of the claw hand. There may be extra or missing ribs, fused vertebrae, even missing bones in the arms or legs. There can be craniosynostosis, which is early closing of the sutures of the skull that need to be surgically opened up so the brain has room to grow. So lots of limb and skeletal bony problems, but not in any pattern that's particularly helpful for making a diagnosis. There can be immune problems, low T cells, and in the extreme case, absent thymus, which creates a severe combined immune deficiency, which is lethal unless someone has a thymus transplant. So obviously extremely important if you have it, but it's only an occasional finding in charge. But it's something that needs to be thought about and looked for in a newborn with charge. Hypotonia means low muscle tone. So sort of low muscle tone and loose joints. And when you add that to the balance problems, that sort of complicates some of the slow motor development in kids with charge. And seizures, up to 40% of kids with charge develop seizures at some point, and that can be anywhere from newborn to adulthood. So those are some of the other features that have been reported in charge. That is not a comprehensive list. There are lots more. Now, beyond these kind of medical structural features, there are other management issues. And you'll hear a lot about several of these later on in the course, but these are some of them. There are a lot of respiratory and anesthesia issues. There are gut issues with cyclic vomiting, abdominal migraines, constipation. We're not sure if those are related to nerve or what. Difficulty potty training, is that a nerve problem or is that a behavioral problem? Is it both? We're not sure. Sleep disturbances of many kinds. Many people with vision loss have abnormal circadian cycles. A lot of people with CHARGE syndrome have sleep apnea, and that could be obstructive because of large tongue or tonsils and adenoids, or it can be central, that the brain isn't giving the message to breathe all the time. Sensory integration. You have all these sensory losses. How do you experience the world? You'll hear a lot more about that and behavior later on in the course. But those are all major issues for families dealing with these children that are trying to figure out how to give them the best life and the best education and everything else. I think you've kind of gotten the point that CHARGE is variable. It's extremely variable. Every single feature that I've mentioned can be absent in some child with CHARGE and severe in another one. So there's the whole range for every feature. At this point in time, we haven't been able to identify any one feature that is seen in every single person with CHARGE. CHD7 testing is really helpful in less clear cases. We do recommend it be done in everybody that has possible CHARGE. Even if the clinical diagnosis has no question, we still recommend the testing. It's really useful to do. A lot of times people hear the terms CHARGE-like or atypical CHARGE or maybe even CHARGE association for someone who isn't really obviously CHARGE but kind of fits in the category. I like those terms. I think they're very useful. I think even if they're getting there through some other gene, that the management issues are really overlapping. And if using CHARGE as part of their description gets you to where you can get the expertise of all the people that have learned about CHARGE, then go ahead and use it. It's great. So even if it turns out to be caused by a different gene, what we learned about managing CHARGE will still be helpful to these people. And so it's great to call them CHARGE-like or something like that. Besides the variability, I've sort of mentioned severe and mild CHARGE a bit. And families often ask me, do you think my child has severe CHARGE or mild CHARGE? And what I've come to believe is severe or mild is different depending on when you're talking about it. So in infancy, I think it's kind of obvious that severity is referring to life-threatening medical issues. You're not really worried about the hearing loss, the vision loss, and that kind of thing if you've got a life-threatening heart defect and breathing problems and immune system problems and that kind of thing. So in infancy, severity is really talking about the birth defects and the medical issues that have to be dealt with to be able to survive. If you survive infancy and you're getting into childhood, certainly ongoing medical problems are still important, but this is where the sensory and behavior things really come into play. So what kind of vision loss you have, what kind of hearing loss you have, how your balance is, what your behavior issues are, those are all things that make communication difficult and make learning difficult. And so someone that has a school-age child with CHARGE is more likely to describe them as severe when they have more sensory issues. By the time you get to adulthood, it's more native intelligence. Presumably hopefully they've had appropriate education and their medical issues are fairly stable. And the question is, can they live independently? How much support do they need? What kind of jobs can they do? That kind of thing. So severe or mild in adulthood is more referring to the intellectual capabilities. So how well do kids with CHARGE do? Well, if you look at the typical 2-year-old with CHARGE, she's probably spent 5 or 6 months in the hospital over that 2 years. She's had at least 6 or 7 different surgeries. She's followed by 10 different medical specialists, and she hasn't even hit the educational system yet. She's probably fed by a gastrostomy tube. She might have a tracheostomy. She's not walking, not talking, nowhere near toilet training, and has some pretty unusual behaviors. If you just took a look at that child, you'd say, oh my goodness, she's so delayed and she's pretty odd. And you would think, oh, she's not going to ever do anything. Well, that's not the case. How much can they catch up? In some cases, a lot. So early delays does not predict ultimate outcome. The spectrum of intelligence in charge is from above normal to extremely impaired. I've had professional adults email me and say, I had these problems when I was a kid, and I got online and I started looking at them, and I think I have charge. And they tell me about themselves and they send me a picture, and sure enough, they have charge, and it just never got diagnosed. So the spectrum is the entire spectrum. I always tell parents to assume normal intelligence until proven otherwise. That long-term outcome, long-term prognosis might be very good. Individuals with charge are input impaired. The information coming in is not complete because of the hearing loss and the vision loss and that sort of thing. So it's taking longer to get information in. Some are output impaired. It's difficult for them to have facial expression or to speak or to communicate. So assessing them is a very, very difficult task, and you'll hear more about that in this course. We absolutely, totally expect delayed motor milestones in people with charge, but that is not a prediction of how they will do otherwise. At one of our very first conferences, we had an adult with charge get up and talk about his life. He actually signed, his father spoke for him, and he says, my name is Daniel, and I'm 24 years old, and I have a dog, and I have a cat, and I live in an apartment, and this is what I do for a living, and this is where I go for vacation, and all that sort of thing. And he talked about it, and he sat down, and his father got up and said, when Daniel was 10, he was lying on the floor looking at Legos. So that's one of the possibilities, is at 10, lying on the floor looking at Legos, and at 24, independent adult. That's certainly not every person with charge, but that's one of the possibilities. So I always try and give families lots and lots of hope. Again, early delay does not predict ultimate outcome. Some people with charge will become completely independent. Most people with charge will require at least some support throughout life, mostly because of the sensory deficits, and some will require complete support for their entire lives. It's the whole spectrum, and we're not going to know early on what it is. I want to say a little bit more about the senses in charge and sensory deficits. You'll hear a lot more about some of this later on, but I just want to really emphasize that children with charge are not just hard of hearing, they're also hard of vision, they're hard of balance, they're hard of smell, they're hard of touch. All the information coming into them is different. And that means that their experience of the world is very different. With sensory losses, you're going to get different development. So all the early motor milestones, think about fix and follow, head control, crawling, sitting, standing, walking, they're all vision-based and affected by balance. Why do you do those things? You see something that you want to get at. If you don't see it, where's your motivation? So the world is experienced differently. All the language milestones are affected obviously by your hearing loss, but it's not just how much hearing do you have. It's what's your hearing like with the aids on? Is it fluctuating? Does it get better and worse with ear infections? That kind of thing. And with vision, are you seeing the person who's speaking to you or signing to you? So the amount of vision and hearing you have is going to affect your communication and your language milestones. And as I mentioned before, learning that is incidental, not taught, but just sort of picked up in typical children has to be specifically taught to those with sensory deficits. So they're not going to see things and observe the reactions in the way typical children do. And so there are a lot of things you're going to have to specifically pay attention to and teach them. And that is true of all children with sensory deficits. And a little bit about that and deaf-blind. I mentioned the term deaf-blind early on. When you hear the word deaf-blind, you kind of think dark room, no sound. That's not really what it is. Deaf-blind is an educational term that refers to any child with some hearing loss and some vision loss. Most children who are considered deaf-blind have some usable vision and or some usable hearing. So if you have someone that's completely blind, you teach them with sound. If you have someone who's completely deaf, you teach them visually. If you have less hearing and less vision, neither of those approaches is exactly right. You need a different approach, which is deaf-blind. And a term that we use in the charge world is the communication bubble. And the communication bubble is how far out and how well can the child see, and how far out, how well can the child hear. Anything outside of that bubble might as well be behind them in the next room, not exist. So you have to figure out where they can get information, where they can access the information and present information to them in that bubble. And children find their own bubble. These are pictures of children working within their bubble. And you can see that they're working very close up. They're exploring with their hands. They're doing things that are getting things within their realm of experience. And figuring out where that is for these kids is really, really important. And a related issue is, I want to show you this chart of the physical influences on development in charge. And this was something developed by my mentor, Dr. Sandra Davenport, who is a pediatrician, medical geneticist, and deaf-blind expert. And what she was trying to think about is what all's going on with these kids. On the left-hand side of this are the external things, the senses. How much can they see? How much can they hear? Can they smell anything? Can they taste anything? How is their experience of touch different from other children? On the internal side are all the things going on in the body. Swallowing problems. Okay, they may have a cleft palate, they may have cranial nerve problems, tracheal or esophageal problems that are going to affect their swallowing and make eating a particular chore, even swallowing their saliva. Breathing issues with choanal atresia, problems with their larynx and their trachea, cranial nerve abnormalities, reflux, all kinds of things affecting their breathing. Many of them end up with trachs because of their breathing problems. Mobility, how well can they get around? They may have limb anomalies. They've almost certainly got vestibular problems and low muscle tone, and that's going to affect how well they can get around. It's also going to make them tire very easily. And that fatigue is also affected by illness. When you're sick, you just don't feel like doing anything, you can't learn, and there's lots of reasons for illness with these kids, including pneumonia and ear infections and poor immune system and all kinds of things. Hospitalizations. We don't expect any development while they're in the hospital, but that's going to also make them tired. They may have a heart defect that was fixed enough that it works, but maybe it's not a normal heart, and so they're going to tire very easily. And all those sleep problems I mentioned, they may not have had good sleep. That's all going to contribute to fatigue. It's very tiring to have charge syndrome. It's hard to get through a whole day. So these are all things that are that sort of tell me that they're experiencing the world differently. And we need to be aware of that when we're thinking about what our expectations of them are. So I really encourage anyone that's working with someone with charge to get to know that child. What's her vision status? What's her vision bubble? What's her hearing bubble? Does it change with her health status or her AIDS or whatever? What's her balance like? What's her overall health? What kind of moods does she have? Observe really carefully. And you'll hear a lot about that from David Brown and Tim Hartshorn and Rob Last later on in this series. So observe them carefully. work on communication. If you don't have communication, you can't do any of the other stuff. So communication, communication, communication. Well, is there anything that can help you get to know that child? Walk a mile in her shoes, or maybe I should say walk a kilometer in her shoes, but the US term is walk a mile in her shoes. I have learned that it is impossible to understand hearing loss and vision loss at a purely intellectual level. Deafblind simulation really, really helps. So I really advise people to do some sort of a deafblind simulation, and whenever possible, get all the people working with the kids, the therapists, the educators, the educational team to participate in a simulation. And over the years, I've come up with a really easy way to do this simulation. You can get some clear plastic glasses from your local novelty store, Oriental Trading Company, or put some tape on them to get a visual field loss, maybe smear them a bit with Vaseline or something to get some visual acuity problems. And then you go to a drugstore and you get some little earplugs. These they're little foam earplugs that you can put in. They're generally a 30 decibel hearing loss, which is considered a mild hearing loss and isn't even always aided. So think about being at that level of hearing without aiding it, and try it out. First thing you'll do is you'll be tipping your head back like the kids to try and see things, and moving around more to try and see things. And I recommend that people try to read something, pick something up and look at it and see how clear does the font need to be, how big does it need to be, what kind of contrast. Try to read something, see what you can see. Have someone present something to you and see if you can tell what they're doing at a distance. You can see who someone is, but can you see their facial expression and get feedback from that? Try and carry on a conversation with someone with this. So it's good to do it in a group. And what you'll find is it's exhausting. It's really hard to do. You have to concentrate to get the information in, both visual and hearing. And so it's a really good way to understand why these kids get so tired, why some of the behaviors happen, because it's hard work to get the information with all these sorts of things. So I really recommend doing a deafblind simulation.